So we will discuss today Vitreoretinal Interface. It's an interesting area, and as you know, the vitreous contains more than 98% of water, and refractive index is 1.33. It has a viscosity more than 2 to 4 times than the water. Vitreous has many collagens, but the most important collagen is type 2 collagens, which is about 75% of the vitreous collagens. And there is a similarities between the vitreous collagen and the cartilage. So when there is an inborn error of collagen type 2, you will have what they call it arthro-ophthalmopathies, because of the similarities between the joints and the vitreous. Other important is the type 9 collagen, because it has an association with Wagner syndrome if there is any genetic mutation in this collagen. Non-collagenous structure proteins of the vitreous, we have fibrillins and opticine. And you know, fibrillins, if there is any genetic mutations, it's associated with Marfan syndrome, which clinically we can see ectopia lentis, and also in some cases there can be retinal detachments. Opticine prevents aggregation of the adjacent collagen fibrils and make it as bundles and separated, so it will be parallel to each other and it will not aggregate together. Also it binds to heparin and chondroitin sulfates, which has an important in the connection of the vitreous to the eye lamp. An important substance in the vitreous, which is hyaluronic acid. It's in some tissues is a major component in the vitreous, in synovial joints, fluids, and also in the skin. And it's in the skin, it's 7 to 9 grams. Average adult weight, which is about 50% of the total hyaluronic acid in the body. It's synthesized by the ciliary body and also by the molar cells, and it has an important because it's a large polyanion, which has an important in the transmission of the drugs in the vitreous. You know, as the main function of the vitreous is the transparency, and it has and this transparency help to transmit the photons to the retina. And other functions, you know, in the normal vitreous, usually the oxygen is attached to it's near to the retina. And if there is an extra oxygen which is diffused to the vitreous, it's react with the ascorbic acid, and it can lead to dehydrated ascorbic acid plus water. But when there is vitreous detachment, posterior vitreous detachment, there will be a space for the roaming of the oxygen, and if there is an extra oxygen, it will diffuse to the vitreous, and it's beyond the scope of ascorbic acid to react with it, so it can cause cataract formation. So the vitreous interface, it's the content, it's the internal limiting membrane, as you can see in this electron microscopy, and the posterior vitreous cortex, and an intervening matrix like the laminin, fibronectin, and chondroitin, which is help to connect the posterior vitreous cortex to the internal limiting membrane. As you can see in this picture, this is ILM, and this is the facing part of the posterior vitreous cortex. And you see there is the connections. There is the points of connections between both, which is the laminin and fibronectin. This is when we have a normal spontaneous posterior vitreous detachments. You can see if there is posterior vitreous detachment, still there is part of the vitreous attached to the internal limiting membrane. So it's not totally in all normal process detached completely. So to have posterior vitreous detachment, you have to have two things, synthesis and syneresis. The synthesis is the gel liquefaction, and you can see here the early liquefaction, then extensive later. And you have to have also syneresis, which is the vitreoretinal dehiscence. You can see this is the acute posterior vitreous detachment with complete. So the right way to say this patient has posterior vitreous detachment, you have to have the gel liquefaction plus the dehiscence or detachments from the internal limiting membrane. So what are the stages of BVD? We said stage 0, absence of BVD, and we have stage 1 when we have perifoveal BVD with vitreofoveal adhesion. So still there is adhesion to the fovea. So this is stage 1. Then we have, when there's detachment of the vitreous from the fovea, we call it macular BVD, which is stage 2. As you can see here in this OCT, this is a stage 1. Usually the BVD started in the perifoveal area. Then we have stage 3, which is near complete BVD, but is still attached to the optic disc. As you can see in this OCT, there is macular detachment of the vitreous, but it's still attached to the optic disc. This is stage 3. Then we have stage 4, which is complete BVD. So when we don't have both gel liquefaction and the syneresis, this is called anomalous PVD. Anomalous PVD, when we have just liquefaction of the vitreous without complete detachment of the vitreous. So if there is in the peripheral fundus advanced gel liquefaction with firm vitreoretinal adhesions, this is caused retinal detachment and tears. But if the attachment is still at the optic disc, the anomalous PVD can cause different vitreopapillopathies. Another important terminology, which is the vitreoschisis. It's a result of anomalous BVD, and you can see this is the internal limiting membrane. This is the retina, and this is the posterior vitreous cortex. And you see the arrangement of the collagen, and you see there's a space between this collagen. So when we have posterior vitreous detachment, instead of the normal process coming at the level of the ILM, it comes between the collagen fibers and splitting these fibers. This is what you call it vitreoschisis. There is an important cell which we call hyalurocytes. It's a monolayer phagocytes, and it's single layer in the posterior vitreous cortex, and it's approximately about 50 micron from the ILM. And this cells has an important in the proliferation and stimulation of inducing contraction. So for example, if the hyalurocytes the splitting in this area, and it's less than 50 micron, it means that the hyalurocytes is still there. So it will cause more proliferation and causing more traction. For example, if the hyalurocytes in this area and it's detached with the vitreous, we will have less proliferation and contraction later. Vitreoschisis was associated with 53% of macular holes and 43% of macular pucker, and it can cause either outward tangential traction, which is inducing macular hole, or either inward tangential traction, which is explain the pathogenesis of macular pucker. Sorry. There is an important also terminology, which is the vitreopapillary adhesions. After anomalous BVD with vitreoschisis, there will be splitting of the posterior vitreous cortex layers. In the absence of vitreopapillary adhesion, the vitreous is not attached to the optic disc. So what will happen? there will be inward tangential interaction, what we call it centropetal. But if the vitreous is still attached to the optic disc, so the vectors of forces will be changed, and the attraction will be outward, which is lead to the tangential interaction, which induces central retinal dehiscence, and this is explain the pathogenesis in macular hole and lamellar hole. So we have two kinds of forces that involved in vitreoretinal diseases, either tangential or anterior-posterior forces. The tangential attraction involved in anomalous PVD and in epiretinal membranes and vitreopapillo adhesions. This happens secondary to the tangential attraction. So this slides can summarize. You see this is the light to gray area where there's asymptomatic, and when it comes down, it's become more symptomatic. So in vitreoretinal attachment in the macula either can complete PVD with fibrosis, and this is epiretinal membrane. If it's getting worse, it can cause macular pucker and getting more symptomatic. Or if it's incomplete PVD with foveal adhesions, will lead to focal vitreomacular adhesions. If it's isolated, we call it vitreomacular traction, which may lead to full thickness macular hole. If it's maybe accompanied by another diseases like diabetic macular edema, which can aggravate the disease. If and the macula, it's retinal layer separation, and it's foveal retinoschisis, and it's may lead to lamellar hole. Or could be the attachment to the optic disc. If it's incomplete PVD with optic disc adhesions, this can lead to vitreopapillary retractions, which is, if the patient is diabetic, can lead to the vitreous hemorrhage. If it's to the vitreous base, it's later can lead to the peripheral retinal tear and retinal detachment. So if we have early stage PVD, it can cause many diseases like epiretinal membranes, macular holes. It can lead to foveal tractions, vitreomacular traction syndromes. A lot of varieties of diseases can happen in early stage of PVD. In later stage, when it's complete PVD, it can lead to either retinal or optic disc hemorrhage. It can lead to retinal tear, retinal detachments. To make it more simpler, if you have abnormal vitreoretinal interface abnormality, either you will have PVD, or you have epiretinal membranes, which lead to pseudo-hole or macular pucker. It can be either macular hole, which can be lamellar or full thickness, or vitreomacular traction. We'll talk briefly about each one, and we'll start with the vitreomacular traction. As you know, the vitreomacular traction happens when you have a peripheral vitreous detachment. So the vitreous is just attached to the macula, and you have a periretinal membrane or periretinal tissues. And nobody knows either the periretinal proliferation can initiate the PVD, or the PVD can initiate the proliferations of the membrane. In the past, they thought VMT is an isolated pathology, but currently it's believed to contribute to a wide spectrum of macular diseases, as in macular edema and macular holes or epiretinal membranes. So it could be a spectrum of the same disease. Based on OCT, the pattern of vitreomacular traction can be divided into two categories. Either on the shape, it can be V-shaped, or can be J-shaped, or it can be classified according to the adhesions, either focal adhesions or broad adhesions. So the V-shaped and focal VMT lead to tractional cystoid macular edema and macular holes, and the G-shaped or broad can lead to epiretinal membrane formation and diffuse retinal thickening. The V-shaped and focal shape cause more traction on the retina because the point of traction is very small. So the surface area of traction is small, so you have more stronger contraction, which can lead to macular holes. But when you have a broad adhesions, there is less contraction, and there is a time for the proliferation of the cells over the retina and causing epiretinal membrane. So the classification based on the diameter of the adhesions, focal or broad, and not on the shape, because it's the adhesions can give more specific macular changes, and it's orient us to the pathology. The treatment of VMT, either to watch for 3 months, because sometimes we have spontaneous resolving of the VMT, but actually sometimes if you keep it, it can lead to deteriorating of vision and can stimulate another pathology as epiretinal membranes. So this is a case. Let's share this case. I saw this case in 2012. Her vision was 2100. She's a diabetic patient, and she's one-eyed patient, and she had macular edema at that time. So we injected her with Avastin. Then she disappeared for around 1 year. Then she came back, and you can see she started to have the detachment of the Vitreous and with traction. So this is cystoid macular edema with secondary to the traction, and it's secondary to the diabetes. You can see with time the posterior Vitreous detachments become more clear, and there is broad attachments, and her vision is getting less with time. So at this time, I thought it can be the time for surgery. But the patient is one-eyed patient. I was hesitant to operate the patients, and also she was hesitant. So I said for her, so maybe we'll inject again and see what will happen. I injected again, then she came 2014, and there's still the same picture. And at that time also I was hesitant to do surgery, and then after that I think I injected also her again. Then she came after 6 months, and you start to have the lamellar macular hole in this area with the tractions getting elevated. So after that she came with already there is detachment, completely detachment of the Vitreous with lamellar hole. And her vision is getting better, 20/60. So I saw her just I think 2 weeks ago, and she's really very happy with her vision, and she is a 20/60 vision. So sometimes we have detachment of the VMT, and observation is the best, especially if you have one-eyed patients. There is a new paradigm for vitreomacular retraction, which is the Ocriplasmin. And the Ocriplasmin targets the fibronectin, laminin, and collagen, and it's helped to separate the vitreous from the Vitreoretinal Interface. And there is many studies about this, the use of Ocriplasmin and VMT, and these studies showed that there is a successful resolution of VMA in 66 to 80% of eyes, and in VMT with macular hole it's less, which is 50 to 62%. The most side effects of Ocriplasmin is the floaters. So to use the guide for use of Ocriplasmin, if you have a patient with VMT and there is no epiretinal membrane, it has a stage 2 macular hole, and the diameter is less than 400 micron, or if the patient has severe symptoms, you can use Ocriplasmin as a treatment. Another entity, which is the epiretinal membrane. The epiretinal membrane is a sheet of avascular fibrocellular tissue formed over the internal limiting membrane. And the epiretinal membrane can be, you have different kind of epiretinal membrane, either cellophane maculopathy, epiretinal fibrosis, or macular buccal when it is thick. And it depends on the type of collagen which is involved. So an epiretinal membrane may also be associated with macular pseudoholes. As you can see in this case, there is an epiretinal membrane, and we have a pseudoholes here because of the traction. It's become steep. So sometimes we have effulsion of epiretinal membranes. The proliferating cells can penetrate the posterior vitreous cortex and proliferate on the anterior face of the posterior vitreous. So when it's detached, it can cause effulsion of the epiretinal membrane. So epiretinal membrane can mimic VMTs, but a Weiss ring, when visible, usually indicates complete PVD, as seen in most patients with epiretinal membrane, which is found in 80 to 95% of cases. Epiretinal membranes may coexist with VMT in 26 to 83% of cases. You can see in this OCT, there is an epiretinal membranes with complete PVD, which is present in 80 to 95% of cases. In this case, you see the posterior vitreous detachment, but there is a missed part of it in this area, which is still attached to the internal limiting membrane. It's the mechanism which happened here is vitreous cases. Epiretinal membrane, the cystoid macular edema differs from epiretinal membrane in that there is no distortion of the microvasculature, and it's always centered on the fovea, and as it can be seen in the fluorescein angiography. So you can see here, this is the epiretinal membrane with distortion of the vasculature, and it's not centered. But in macular edema, it's centered, and there is no contraction on the blood vessels. This is a study which was done at our hospital, and it was presented in the last Saudi meeting. The purpose is to evaluate the predicting factors for good visual acuity after pars plana vitrectomy for epiretinal membrane associated with diabetic macular edema. It was around 29 eyes. And the conclusion of this study that showed improvement in visual acuity after pars plana vitrectomy and epiretinal membrane removal. Patients with better initial visual acuity achieved higher levels of visual outcome, and post-operative improvement in vision is slow. So these patients may need to wait at least 6 months to improve their vision. There is some patients sometimes present to the clinic and complaining they have distortion of their vision, and they have small scotoma, metamorphopsia, and when there is no signs of sun gazing or any injury, and when you examine the patients, you will find there is a red spots. I don't know, is it clear for you? And usually it's very small. Sometimes we don't notice this. And when you examine a patient, we said there is nothing clear. But when you do OCT for these patients, you will see there is an interruption of the photoreceptors. So there is a break in photoreceptors, and it's present in 83% of cases. So this is what we call it fovea red spot. And it is secondary to attraction of the vitreous in the fovea. Then the patient has this complaint. So when you have a patient who has this complaint, so please try to do OCT and focus on the photoreceptor. Another entity which can affect the vitreoretinal interface is the traction, diabetic macular edema. And it can be exacerbated by VMT if it's present. Usually it's a stage 1 PVD. And interesting, they found that the diffuse diabetic macular edema is characterized by a layer of native vitreous collagen and varying cellular components. So they found just one layer of vitreous is attached to the eye lamp. But in cases when there is tractional vitreomacular, it's associated with multi-layer membranes situated in a layer of vitreous collagen. So we'll go also to another entity, which is the macular hole. As you know, macular hole, the pathophysiology is not clear, but gas postulated. There is a breakdown of the compact arrangement of the molar cells, and perhaps their movement into the perifoveal vitreous cortex, initiating the contraction. This the molar cells. It's extended from the internal limiting membrane, which is the input of the external internal limiting membrane, and extend to the external limiting membrane. So it's just its work as holding the retinal structures and keeping the shape of the retina. So what's happened in macular hole? Usually there is the starting point. So there is a proliferation of the molar cells and move anteriorly over the vitreous cortex and start to proliferate. And when it start to proliferate, it's pull up the fovea, and we have foveal detachments. This dotted area is the xanthophyll. So with more pulling of the fovea, the xanthophyll will move away from the center, and this is what we can see clinically as yellow spot. And you can see the proliferation of the molar cells. It's come tangential. It's not anterior-posterior. It's more tangential traction. So this is later will lead to tear of the retina. So as you know, the macular hole stages, we have the stage 1A, which is foveal detachment. Then we have stage 1B, which is more proliferation of the molar cells in this proliferation. And they will pull more the retina away until we reach the stage 3 and stage 4 with complete PVD. So another entity, which is the lamellar macular hole, it's thought to be, it could be secondary to the union of intraretinal cyst, or could be secondary to aborted formation of full thickness macular hole, and the mechanism is centrifugal traction of epiretinal membranes. This is how does it happen. If you have a thick epiretinal membranes, it's pulled away on the retina, which is the tangential traction. It's outward traction and lead to splitting of the retinal tissue, but you will still have some of the retinal tissues is still attached. So there is the recent reports. It was in this year about the lamellar macular hole, and they thought it's two entities. It's not just one entity, and they divided this lamellar macular hole to tractional macular hole and degenerative lamellar hole. The tractional lamellar hole it's characterized by there is a schisis, and this schisis does not spare the central foveal region. So it's affect the foveal region, and there will be a clear epiretinal membranes which is cause this traction, and there is ellipsoid area is still intact. So the photoreceptors area is still intact, is not affected in tractional lamellar hole. While in the degenerative type, there is a loss of retinal tissue, and there is a retinal bump which is still there. And there is disruption of the ellipsoid layer, and you can see there is no interconnecting retinal tissues. This is more explanation where you have the tractional lamellar hole. You can see the schisis between the outer nuclear layer and the outer plexiform layer. And you can see there is an epiretinal membrane, which is cause elevation and traction. And there is intraretinal cystoid spaces. In the retina, there is a cystoid spaces. While in degenerative type, intraretinal, it's cavitation. There is a loss of retinal tissues. And the epiretinal membranes, it's contact with the retina, and it's not causing traction on the retina. And there is no intraretinal cyst, which is present in tractional lamellar hole. And in the tractional type, you see it's like a top hat appearance. You can see here it's ellipsoid shape, but in the degenerative type, it's a mustache-like appearance. And if you look to the history, the tractional lamellar hole, for example, this patient was presented in 2014, and it's progressive fastly, and see in 2015, this is full tractional lamellar hole. While in the degenerative type, it's a slow history. This patient was present first 2019, and it's getting a complete picture in 2015. So other entity, just to differentiate, there's an tractional components of these diseases, while in the degenerative type there is no traction. You can see traction in epiretinal membranes and macular pseudohole and myopic retinoschisis and the tractional lamellar hole, but we didn't see traction in degenerative lamellar hole. You can see this. What's this type? This is the degenerative type, and this is the microperimetry. You see in the beginning of the disease, the microperimetry is still normal. When the disease is getting progress, you can see there is interruption of the photoreceptors, and start the microperimetry sensitivity decrease. And when the disease is getting more, there is a lot of loss in this area of the photoreceptors, and you can see the microperimetry getting more decreasing in sensitivity. So it's important to differentiate between the lamellar macular hole and macular pseudohole. So this is the lamellar macular hole, and what we can see, and you can see here there is a regular thinning of the foveal base, and you can see there is a break in the inner fovea, and intraretinal split, as you can see, it's clear, and there is normal perifoveal thickness. The thickness here is normal. While in the pseudohole, the normal central retinal thickness, because we don't have a loss of retinal tissue, and there is a steepened defect of the fovea because of the pulling of the epiretinal membranes, and we can see also epiretinal membranes is clear, and there is an increase in the thickness of perifoveal area because of the traction. So in conclusion, many retinal diseases affect the vitreoretinal interface with different clinical aspects. High-tech devices as OCT help in understanding the vitreoretinal interface pathology. Advancement in medical retina and vitreoretinal surgery has a role in a better visual prognosis and a good quality of life. Thank you.
Thank you, Dr. Ali, for an interesting topic that usually you don't find in textbooks, and it needs a lot of time to collect the information. I will leave the floor for questions.
Thank you very much, Dr. Halafi. Very nice, illustrative talk. Now, my question is, when you have macular or epiretinal membranes and with edema, now, be it diabetic or non-diabetic, we know once we peel the, or mostly the ILM and this epiretinal membrane, they will form like a complex. But sometimes even if you separate the membrane and then the ILM remains, one can go for. But there are few studies shown that peeling the ILM after removing the epiretinal membrane does not add to the success of surgery, or to the success, or to a better visual improvement rather. First, why is this? And secondly, is why the visual recovery after peeling epiretinal membranes takes long time for the vision to stabilize. Even sometimes the edema goes away. Does this relate to the ellipsoid layer, and do you look to this preoperatively, Ali?
Yeah, most likely, as you say, it's maybe related to the ellipsoid area. I found 3 cases in my study, which has interruption of the photoreceptors layers, and they didn't improve even after the removal of epiretinal membranes. Even after 6 months, they didn't improve. So I think this is the chronicity of the disease affect the results. This is why if you interfere in the early stages of the disease, may you get good results after surgery.
This is what now, because the trend, the old trend is not to interfere with the epiretinal membranes unless they affect vision. Some they say 20/40 or 20/60 or less. But it seems that with to keep the integrity of the ellipsoid layer, probably if we go earlier, better for the patient.
Absolutely,
even without metamorphopsia or other problem.
To operate patient who is not symptomatic, I don't think it's the time to operate. But when the patient start to have symptoms, and I think it's the time to operate.
Symptoms
Because
like metamorphopsia or decrease of vision.
Metamorphopsia, when you start to have symptomatic. Decrease of vision, I think it's not the good sign to rely on it to operate in these cases. And also it's important to do OCT and make sure about the photoreceptors it's intact. If it's not intact, actually even the result of surgery, it will not be as good as if it's intact.
You mean the prognosis?
The prognosis.
Why sometimes peeling off the ILM, if it is not firmly adherent to start with and we peel it both together, why it doesn't add to the sort of the prognostic success of ILM peeling?
I don't know the answer, but the ILM peeling, it's a controversial area of research and also between the surgeons. That some they said if you don't peel, you will not have any addition improvement in vision, especially in diabetic macular edema. But they thought, for example, in diabetic macular edema, when you peel the ILM, it may help to the fluid to escape to the vitreous, and also
as if removing the barrier.
As if you're removing a barrier. And in macular hole, ILM peeling, it helps to remove the tangential traction on the macular hole, which has helped to relax the hole. And now they doing inverted ILM when you do the surgery. Don't remove the ILM completely. Just trim it at the end, then just flap it over the macular hole, and this may help to heal the holes.
Thank you very much, Dr. Ali. Very interesting. Very interesting topic and very interesting coverage for the topic. I think one of the main reasons for ILM peeling in epiretinal membrane is to decrease the recurrence rate. Okay, because cells will not proliferate. They need the limiting membrane, yes, to reproliferate again. This is the main reason to peel ILM peeling, ILM and epiretinal membrane. But for the macular hole, as Dr. Ali mentioned, the tangential traction and to enhance the hole to reattach again.
Yeah.
Subject, this was really nowadays, is the error of removing this membrane, especially with using this staining. find any help from special care that will help, especially for with because to say that in the cases like, especially in the patient, first layer of the membranes, you might find another layers until you get to the ILM. The other thing is there any difference between epiretinal membrane in diabetic patient versus idiopathic types?
Yeah, regarding the vitreous cases, it's common in diabetic patients. And the best way to find it is to inject a triamcinolone. Triamcinolone can attach to the vitreous, and it's clear when you see when you remove part of the vitreous, there is still another layer of the vitreous. Also, when you peel the ILM, sometimes it's helped to remove completely the vitreous. My routine when doing vitrectomy, I inject routinely triamcinolone. So I think the best material is the triamcinolone to help you to show the vitreous. And regarding epiretinal membrane in diabetic or non-diabetic patients, I think in diabetic patients, there is the epiretinal membrane is causing more traction on the retina, and the retina is more fragile to cause the traction and cause macular edema. So I think it's aggravate diabetic macular edema. But exactly how does it differ exactly, I don't know.
There is one other points about the classifications. You mentioned that focal and broad. And there is another category that called Vitreo VMA, vitreomacular adhesions.
Yes.
What is the significance of this versus focal and broad spectrum? Because that's important, especially when you are going to do surgery in this patient, when you have to interfere, when you have to leave it.
When you have the focal attachments, there is a strong attachment on the fovea because it's small points of attachment. So the best way to release this traction. What's your second question? Yeah, if you have broad attachments, it means that maybe you have a epiretinal membrane, and with this, for example, macular edema, so maybe you need to do more staining to visualize the epiretinal membranes. Lamellar macular hole, yes.
Thank you very much. Thank you, Ali. I really enjoyed it. To answer, or to attempt to answer the question of Dr. Al-Amru and why does the vision not improve by the additional ILM peeling, while I agree with the response of Dr. Qahtani saying that it helps to prevent the recurrence, and for sure we know that the latest studies show that the recurrence rate of macular hole is less when you do an ILM peeling than when you do not do an ILM peeling. But those studies have looked at the anatomic results primarily and the subsequent visual acuity results that result from the fact that now you have a closed hole. But when you talk about people who don't have holes in general, whose potential for vision recovery is good, provided that the outer retina is not completely disruptive, adding an ILM peel may help stabilize the anatomy of the retina, but it will not help vision because the ILM is part of the Macular cells. And the Macular cells are extremely helpful in the transmission of the visual impulse. And therefore, it makes sense not to peel zealously.
It's
with overzeal. I mean, if you don't need to peel the ILM, if you need to do it because you want to help close the macular hole, it makes sense.
But anatomically, the success rate is better when you peel the ILM.
When you peel the ILM, but the question was, why doesn't the vision improve much more? Why doesn't the peeling of the ILM help improve the vision? That was, I think, Dr. Al-Amru's question. And I think it is because you are doing something to a cell that helps the integrity of the retina. That's right. That's right. The other thing I wanted to say is that Ocriplasmin is only indicated in very focal adhesions. And what they found out is because it dissolves all this laminin and fibrin fibronectin that's in the retina, that it actually, when you peel or when you inject Ocriplasmin to relieve a vitreomacular adhesion or traction, usually for traction, focal tractions, what these people get very often, because of the dissolution of the retina, you get subretinal fluid, which is practically, it's counterintuitive, because you would think that if you do a retinal surgery and you're peeling the ILM, you're causing traction, and then you may see some subretinal fluid underneath. But we hardly ever see subretinal fluid after a simple peeling of a vitreomacular traction. But we've seen it in Ocriplasmin, and that's been studied right now.
Do you know the reason for loss of vision in Ocriplasmin, temporary loss of vision? They post.
Electrophysiologically, they're disturbed. I know that there are ERG disturbances after Ocriplasmin injection, and I know that people have some vitelliform lesions or subfoveal fluid after Ocriplasmin. So it's not that's been studied. There's an ongoing debate right now whether Ocriplasmin is as good as it should be, whether it's safe enough.
Thank you very much, Dr. Ali.